Okay, the next candidate.
Yes, sir.
How are you, my friend?
I'm good, sir.
Okay, يلا, easy case, but urgent one. What do you
Oh,
see in this patient with fever and odynophagia?
okay, sir. I have been provided with a lateral view of the extra neck of an adult patient, in which I can see that there is swelling of the epiglottis with the thumb sign positive. There is also mild
Excellent.
prominence of the palatine tonsil. The retropharyngeal or prevertebral space thickness appears normal, with normal visualized density and end plate density of the vertebral bodies and the height
Good.
of the intervertebral disc spaces. There
Good.
is also mild fullness of soft tissue in the floor of the mouth. So I would be immediately picking up the phone and informing the referring physician, and this patient requires urgent ENT referral for possible
Excellent.
epiglottitis and inflammation in the floor of the mouth, could be Ludwig's angina as well. I would suggest airway maintenance by the ENT specialist, which could require intubation or cricothyroidotomy. And
Good.
this should be followed by a contrast enhanced CT scan of the neck and floor of mouth to see for the extent of disease process, and starting the patient on empirical antibiotics and follow up with if there is possible pus, then that can be drained and that would be further cultured
Very good.
for
Very good, my
targeted
friend.
antibiotic therapy.
Okay. What is the expected causative organism? Viral or bacterial?
So bacterial.
Okay. And what is the expected age group?
Expected age group is usually for epiglottitis, it is usually school-going children, but in an adult patient, this could be because of
Yes, it has.
immunocompromised status.
Yeah, yeah, by model because this is adult. Okay. In young children, what is the expected age also?
So, school-going children,
Okay, okay, yes,
above.
more than 3 years. It's older age group than group. Okay,
Yes.
in a group, less than 3 years, from 6 months to 3 years, and usually it's a viral infection. Very good, my friend. This is a very important case. Again, short reporting rather than oral. We have a thickening, marked thickening of the epiglottis. It's called thumb sign. Okay, and we have also enlargement of this area related to the epiglottis, which is
Epiglottic folds.
excellent area epiglottic fold. Normal subglottic air column, normal hypopharynx, it's not distended, unlike cases of croup, normal prevertebral soft tissue thickness, and unremarkable bony skeleton. So this is a classic case of epiglottitis. Yes, I need urgent. We have to add a word urgent in the referral. Okay, and urgent airway protection, immediate commencement of the treatment. CT with contrast may be also of value. Very good, my friend. It's very important case. What about, we finished this one. Okay. Just a minute. Also, another case of, no, 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 it's not classic for Ludwig angina. Okay, let's see this case, my friends. Nasal obstruction, acute nasal obstruction. Do you want the control?
Yes, sir. I will ask for control.
Okay, okay. Start, يا boss.
Okay, so I've been provided with axial T2-weighted MRI images in a patient who has presented with nasal discharge. I will first scroll through the images, reach to the top cut, and then I will explain my findings. So this is the topmost cut available. I can see that there is a disease process involving the left-sided paranasal sinuses. There is mild mucosal hyperintensity of the
Good.
left frontal sinus, and inferiorly there is also involvement of the left ethmoidal air cells,
Good.
and there is also expansion of the involved sinuses. Inferiorly, there is involvement of the left maxillary sinus as well.
Good.
And left sphenoid sinus is also partially involved. These sinuses show mucosal hyperintensity. However, the central part of the sinus appears black, which could be misleading if this is fungal infection, which I would like to correlate with
Excellent.
CT scan if available. Other than
No, why CT scan? You have many sequences in MRI. Okay.
okay, okay. So
Uh,
rest, I am looking at the retromaxillary fat planes if there is any dirty signal there, which I
good.
don't see. I also would like to look at the cavernous sinus and the
Excellent
orbit.
point. Good.
So the cavernous sinus appears largely intact signal. There is no bulging of its lateral wall,
Good.
and on the involvement of the orbit, I can see that there is bulge into the medial wall. There is displacement of the medial rectus muscle, but there is no overt abnormal signal intensity within the fats or fat of the left orbit, and the globe also appears to be intact. Um,
With no definite subperiosteal collection. Very good.
no, yes. Also looking at the brain, I can see that there is no
Excellent.
abnormal signal intensity within the brain parenchyma and also
Good.
in the extra-axial CSF spaces. I do
Good.
not see any obvious collection. This is most likely a case of invasive fungal sinusitis, but
Are you
I do
sure?
not see. Okay, so this could represent.
From this
Yes,
sequence only
no,
sinusitis.
yes,
Okay,
sinusitis,
I
but
wanted to correlate with other sequences to rule out. Okay,
yes, yes.
good,
I
good.
would
I
like to look at post-contrast images to see if there is mucosal enhancement or there is
step by
uh,
step, step by step. Okay, I'm sorry, I stop you. Okay, this for educational purpose. Here you saw dark signal, maybe air, maybe fungal. First point, I want to correlate with what? Post
with other
contrast
sequence,
or
post-contrast
T1?
sequence. So T1 weighted sequence,
Looking for what?
looking for any hyper intense signal of inspissated secretions.
And the consequent and a comparison of these dark areas. Is it soft
Yes.
tissue or just air?
Mm-hmm.
This is a
Okay.
confirmation. Now you can scroll and tell me.
So the involved areas which appear low signal intensity on T2 appear hyper intense on T1 weighted sequence, which confirms a solid nature. And this is not air. So this is
Good,
not a false pneumatization. This is false pneumatization sign, and
excellent, yes.
this could represent allergic fungal sinusitis if there since there is no evidence of invasion. However, I would like to confirm on post contrast images as well to see if there is
Yes, yes.
enhancement of mucosa. However, I do not see any frank invasion into the orbit, into the retromaxillary space, or into the
Okay,
cavernous sinus and brain.
I will give you the post contrast. So now it's fungal. You see, my friends, fungal, no aggressive criteria, allergic fungal sinusitis. So in a step by step, now in the post contrast, I will enlarge the image again.
Okay. So I'm scrolling.
Yes, yes,
I'm focusing on the left-sided paranasal sinuses, and I can see that there is enhancement of the mucosa again
good.
with no definite invasion of the surrounding structures as previously described. So this is likely a case of allergic fungal sinusitis
Yes,
with no
pertinent
signs of
negative, no
invasion.
subperiosteal abscess, no
This
brain affection, no epidural or subdural abscess, and patent
patent
cavernous sinus. Yes,
superior
cavernous
ophthalmic vein and
and
cavernous
superior
sinus.
ophthalmic
No.
veins, no thrombus. Excellent, my friend. It's a simple case also, but very important. Yes, if you suspected any aggressive criteria, you may indicate CT scan. Now, you
Hmm.
may indicate CT scan if
Okay.
suspected criteria. Otherwise, urgent ENT referral for يعني immediate treatment and follow up. Okay.
Okay,
Uh,
sir.
I I'll give you another case because this one is you managed it well. So I'll give you easy one. Let's see this one easy or no. I want a very hard case. Whoa. Okay. No. Okay, this one is easy. Yes. Uh, we covered some cases of paranasal and orbit. Now another group. Okay. Let's see.
Mm.
Patient has some suspected otitis media and confusion.
Okay, so I've been provided with axial contrast enhanced CT scan of a young patient who is 8 years old, who has presented with otitis media. I
This
will first,
case is important as long reporting. It's يعني repeated many times.
yes, sir. So I'm scrolling through the images. I've been provided with post-contrast images. I will go to the topmost cut, and then I will come back to the area of interest, which is the posterior fossa. Then coming down, I am focusing on the blood vessels. I can see that there is a filling defect in the right
Yes,
lateral part of the transverse sinus, also into the sigmoid sinus, and inferiorly into the internal jugular vein as well,
good. So lack
which
of
is in
enhancement
keeping, yes,
and
which is
distension.
distension, which is in keeping with thrombosis. I would like to look at the bone window to see if there is, I can see that there is loss of the normal aeration of the mastoid hair
Excellent.
cells.
Yes, yes. Before bone window, you should detect it from this window. Okay, excellent, excellent.
Yes.
And look up
So
also some in the middle ear also.
middle ear also there is some opacification. I am
Excellent,
looking at the brain parenchyma. I do not see any ring enhancing lesion or any
excellent.
area of significantly reduced density in the cerebellar hemisphere on the right side.
Good, good.
And I
Oh,
also do not see any peripherally enhancing collection in the extraaxial
excellent.
space.
And no
Uh,
significant meningitis also. This is the bone window confirmed this finding. Okay. So
okay.
it's easy case. Your diagnosis is
My diagnosis is right-sided automastoiditis
yes.
with secondary dural venous sinus thrombosis, also known as dural venous occlusive disease if it is post-infective. And I will
Good.
convey my findings to the referring physician, suggest urgent ENT evaluation, and also installation of anticoagulants if required.
Anticoagulant, yes, excellent. Urgent ENT, anticoagulant. No brain abscess in the bone window, in addition to the opacification of the middle ear cavity and mastoid, so automastoiditis. Okay, intact pertinent negative, intact bony outline, no
Yes.
cerebellar abscess with intact bony outline. The reverse, the opposite. If irregularity here with cerebral abscess, we can call this one just mastoiditis or what?
Sorry, coalescent mastoiditis.
Coalescent mastoiditis, excellent, excellent. Yes, the breach inside the brain. But if the
Yes.
breach is outside with some abscess formation here in the subcutaneous, we call it
That's called Bizold abscess.
basal abscess. Excellent, my friend. Well done, well done, well done. So
Thank you.
remember sinogenic etiology. Okay, it can occur in the paranasal sinuses or mastoid and middle ear cavity. Very important to assess the dural sinuses for any thrombosis and also the subdural or epidural collection and also abscess in the brain. Thank you, my friend. Well done, Yavos.
Thank you, sir.
Okay, the next candidate.
Hello, sir. Good evening.
Good evening. How are you, my friend?
I am fine, sir.
Okay, let's see another case. Easy one. Yes, just neck pain, dysphagia, middle age. What do you see?
Yeah, yes, sir. Okay. Here I am presented with the lateral radiograph of the lateral radiograph of soft tissue neck. Here I can see that there is a increased prevertebral soft tissue shadow is noted with multiple lucencies inside it, and that the epicenter of the lesion mainly between C2, C3, C4, and C5 vertebral body, and that
Good,
is causing some bulge on the airway as well.
good,
Then I can see that there is a reduced intervertebral disc space is noted.
excellent.
Reduced intervertebral disc space at C3, C4 level with erosions at anterior part. Uh, uh, and I cannot see any radiodense foreign body within the prevertebral collection.
Good,
Uh, then the uh, uh, this can be the spondylodiscitis with prevertebral abscess formation. I am checking for any skip lesions are there in the at the rest of the sites. The
good,
other vertebral body
very
looks
good.
normal, and then the other causes I want to rule out that there is no evidence of epiglottitis is there, no evidence of any
Just
airway.
okay, I'll stop you here. Do you see the epiglottis or trachea well?
No, sir, it's
So
more
is
radial
this a
different.
cervical spine or lateral neck radiograph?
It's the cervical spine radiograph.
Yes, this is a lateral cervical spine. I can see the rest of the soft tissues. If suspecting a lateral spine, a cervical spine, then definitely we have EP. If you suspected lateral soft tissue neck, no EB view. But if you suspected lateral spine, so you have to ask for a correlation with other orthogonal. Okay, so in
Yes, sir.
such case, if you don't see the epiglottis, don't comment on it. Okay, my friend.
Yes,
You did very well here in the description, and you gave me spondylodiscitis. Now, after correlation with the frontal, why frontal is important? I give you frontal and tell me why
because
frontal.
in frontal I can see the upper part of the chest. There may be some
Excellent.
nodular opacities.
Excellent. So pertinent negative here, positive or negative? No nodular
Yeah.
opacity, no
No,
cavitations. Okay,
yes,
very
sir.
good. Okay, my friend. So diagnosis and management, and I will summarize later.
Yeah. Diagnosis in the spondylodiscitis with prevertebral abscess formation with
Good.
some bulge on the airway. So this is urgent finding. I will immediately pick up my phone, inform the finding to the referral and urgent ENT referral, and secure the airway, and then
Excellent.
the MRI of the cervical spine to see the spondylodiscitis, especially the epidural collection to see any epidural collection is there, and then the look for the contrast enhanced CT scan chest to any mediastinal extension, as well as there is any thrombus
Excellent.
of internal jugular vein to rule out Lermire syndrome, and also check for any mediastinitis, and also check the lung window to any cause like there may be tree inward appearance or
Very good.
lymphadenopathy to rule out
Very good.
tuberculosis.
Excellent, my
And
friend. Excellent. This case may present in the exam as per se, just soft tissue or just X-ray, or it can be seen as a barium, I'm sorry, contrast swallow. And the examiner telling you it's just a dysphagia. Okay. Prevertebral, significant prevertebral soft tissue technique. You see, my friends, it's a diffuse, not abrupt. So definitely it's an abscess. Multiple air foci, this may be a distractor. Oh, I see retropharyngeal abscess. No, wait. Do you see any foreign body? No foreign body. Do you see the etiology? Either foreign body or spondylodiscitis. Middle age or even older age, I'm expecting the degeneration down. So this is not accepted. Focal narrowing of the disc space here, not accepted. And especially it's in the center of soft tissue thickening. Definitely this is a source. It's a spondylodiscitis, okay, with prevertebral abscess formation. I have to ask for CT and MRI. CT for the bone and the involvement of the imaging of the upper chest or the chest as a whole, and MRI to detect any neurosurgical emergencies at epidural component. So very good, my friend. Urgent ENT referral and urgent imaging, MRI cervical spine, CT neck and chest, okay, and also laboratory test, inflammatory markers, and rule out any TB because I'm suspecting TB. Pertinent negative mentioned by our friend, very good point. No other similar lesions, no skip lesions. Okay, highly specific in case of TB and unremarkable upper chest. Because if any suspected nodularity or cavitations, then it's definite tuberculosis. We add two additional points: immediate isolation, screening of relatives, and of course, one additional imaging finding: urgent drainage and sent for culture and sensitivity. If you see chest finding, then sputum culture and sensitivity. It's very important exam case, oral and short reporting as well. Okay, I'll give you now. Let's see this. case, I'll give you the control. Yeah. Okay. Fever and chest pain. Just I will close this. Okay. Fever, dysphagia, and chest pain. Okay.
Yeah. Here I am presented with the contrast enhanced CT scan neck. Patient presented with the fever, dysphagia, and chest pain. I am scrolling from first cut to the last cut. Here in my initial scroll, I can see that there is a significant collection is noted in the uh, um, in the mediastinum with air fluid level. Then I am going on the upside, checking the cause of this collection from where it's coming. And then I am going in the upper part. So I can see that there is a, in the left side of the mandible, there is a cortical break I can see, which I confirm on the soft tissue window. This can be a odontogenic infection which is trickled down in the mediastinum.
Not the source of يعني the epicenter of the inflammatory process. Not the epicenter, because if the epicenter in the mandible, most of the inflammatory process will be around it. Okay, but here the air collections in the superior mediastinum and also extending along the retropharyngeal area. If you trace the air, it will extend to the retropharyngeal area. Very good, my friend. What else in the mediastinum?
In the mediastinum, I want to check the
The fluid
there is
tracing
a
between the vessels, fluid or air fluid between the vessels, no definite lymphadenopathy. Very good.
yeah. I want to check the lung window as well to see any septic emboli are there, because there is a large collection is there in this
Excellent.
area.
Excellent. Good.
And I want to see any vessel is thrombosed. So I am checking for the vessels. There is, I am especially checking for the internal jugular vein. There is no obvious
Excellent.
internal jugular vein
Good.
thrombosis.
And lung window was unremarkable. Very good. Very good.
Yeah.
So vessels unremarkable, no jugular thrombosis. It's not and lung unremarkable. So not Lemierre disease. But you started from here. Air is filling the retropharyngeal air space. Okay, and traced down now air fluid levels at the base of the neck and in the superior mediastinum. Significant smudging fat, no bony destruction. Okay, what is your diagnosis and management?
This is a mediastinal abscess.
Good.
With evidence of mediastinitis is there, and the collection is also extending in the neck region.
Good.
On the left side.
So most likely it's a retropharyngeal inflammatory process complicated by mediastinitis and mediastinal abscess. Excellent management.
This is a urgent finding. I will immediately pick up my phone and inform the finding to the referring physician, and urgent referral to the chest
Cardiothoracic, yes.
Cardiothoracic surgeon to drainage and appropriate culture sensitivity and sensitivity and appropriate IV antibiotics.
Yes, it's a very high emergency. By the way, mediastinitis can be fatal condition. It's not like the usual abscess, by the way. It's fatal condition. Okay. Thank you, my friend. Thank you. Well done. Well done, Yabos. Well done. Okay. Okay, I will take the control now. Okay, the next candidate يا شباب. Dr. Ali. Oh, we finished Dr. Ali or what?
No, we have still candidate number 6, I think, because I didn't see candidate number 5.
No, I'm here. Sorry, I just did not change my name to candidate number 5.
Okay. No problem. No problem.
Yeah.
Okay, boss. Difficulty in breathing. Proceed.
Okay, so this is a lateral radiograph of a cervical spine and calvarium of a child. It shows that there is swelling in the soft tissue of the epiglottis, as well as widening of the pharynx.
Swelling
There,
in the epiglottis, this area.
actually, I mean the area above it. I'm just
So
maybe
anatomy.
anatomy.
Ah,
So is this the what is it called? Sorry, the name escapes me. Yeah, I'm really sorry about that sad face.
tears. You see tears. Okay. Anatomy. This is a soft
I know it. I know it.
palate. Okay, and
Soft
this is a
sorry.
palatine tonsil.
Okay,
Palatine
palatine
tonsillitis.
tonsil.
Okay.
Okay,
So the
okay.
diagnosis will be
Tonsillitis.
okay. خلاص الدموع
More.
طلعت بره. Okay. The tears outside the face now. This is
Honestly,
distractor, my friend. This is distractor, and this
is
is
it?
distractor. The patient will not die from adenoid, will not die from tonsillitis, but definitely will die from
Is this a retrotracheal, sorry, retropharyngeal infection that is extending?
no. Abrupt change is not
Oh,
an abscess. You see, prevertebral
mhm.
soft tissue, abrupt change. Why the hypopharynx is maximally distended like this? Because we have obstruction.
This obstruction, yes, exactly.
Yes,
Yes, yes, yes.
subglottic narrowing.
Mhm,
What
mhm.
do you mean by subglottic narrowing? Group,
Group,
laryngeo,
yes.
tracheobronchitis. Forgive me, I know it's a tricky case because the center of the image is here, not here. It's
No,
film
it's fine.
edge. Film edge.
Yeah,
I know it's a
yeah.
distractor. Forgive me, my friend. Okay?
No,
Uh,
it's good.
because
Yeah.
anyone, we look at this area. Oh, especially younger colleagues. Okay, I see adenoid hypertrophy. No, he doesn't mean this. But what about this soft tissue? It's a tonsillar hypertrophy, nothing. Adenoid hypertrophy and tonsillar hypertrophy, nothing. But the clue will be here. Why? Expansion of the hypopharynx because we have depression here. I'm sorry, stenosis here. Subglottic narrowing means group.
Group.
I need to protect the airway, maybe adrenaline inhaler or whatever. It's an emergency, high emergency case. Causative organism.
I'm sorry.
I no problem,
I
no
know it,
problem.
but I forgot it.
It's viral. Generally, it's viral. Haemophilus influenza, as I remember. Okay,
Yeah.
so it's viral. Unlike epiglottitis, it's bacterial. Okay,
Yeah.
and the age group from you see, it's very young, very young, 6 months to 3 years. Okay, it's very, very important case. By the way, it's good you did the mistake, so you will never forget it.
Yeah.
Okay? Don't
Yeah.
forget this one. Adenoid and tonsil, easy cases. So look for prevertebral abscess, yes. For epiglottitis,
Yeah.
yes. For croup. These are three emergencies. And of course, foreign body. Okay.
Doctor, can you just, if you don't mind, can you delineate the steeple sign on the
لا,
previous radiograph?
steeple AB. Steeple sign
Okay.
in the AP, not in the lateral. Okay?
Okay. Okay.
Because
Thank you.
steeple sign is like something like this. Okay?
Yeah.
اللي هي
Okay.
شبه قبة الجامع أو كده. تمام؟ Okay.
ماشي.
So in
Okay.
the frontal view. Okay.